Welcome. My name is Chris Steele, and I'm with Peer Consulting. We work across industry and healthcare, and frequently we look to bring leaders from all sides of the industry together for discussions on important topics like this. Thank you for those of you who joined us on the webcast. Thank you also for those that have struggled in through the New York rain today, what we call in Scotland a very drísh day. That's perhaps a new word for some of you. The topic for today is improving health in the community. Not only health in areas which have been traditionally very well served by healthcare, but perhaps more interestingly, looking at how we can create a rising tide that lifts all boats and improve the quality of health in areas which have been perhaps less well served, either rurally or in some of our poorer urban areas. I think, well, first of all, we've chosen health as opposed to healthcare quite deliberately as a broader subject for discussion. I think that's perhaps best illustrated by an anecdote. One of my colleagues met with Michael McGarry, who's joining us today, from Ascension Health. And he said actually what most people need in their communities is not healthcare, but a cook so they eat more healthily, a chauffeur to drive them so when it's wet and snowy they don't risk falling, and a carpenter to perhaps adjust their house so it's more accessible to them. And I think that certainly resonated with me very strongly. So though we may talk about accountable care and patient-centered medical homes, we'll certainly talk about health more broadly also. So let me quickly introduce the panel. We have Steve Epstein, who is an emergency room physician at Beth Israel Deaconess Hospital in Boston. He's also in the Department of Emergency Medicine at Harvard. We've got Kathy Bowles, who's a professor at University of Pennsylvania Nursing School and is also Vice President of Home Care Policy at Visiting Nurse Services of New York. Esther Dyson, who is founder of Hiccup, the mission of which organization is very closely aligned to the topic today, and she's also chairman of ED Venture Holdings. Matt Porsche, Vice President of Commercial Innovation at Commercial Effectiveness, at Pfizer in the Innovative Products Group, and then Anish Kumar, who's head of customer strategy at Aetna. So a great panel we have for you today. What I'm going to do is ask each of them to speak for no more than 5 minutes, just to introduce themselves and their perspective on the topic. We'll then get straight into Q&A for a discussion. We will have questions from the webcast as well as from the room, and I will do my very best to make sure all of them get covered in advance. So thank you very much, and over to you, Steve.
Good afternoon. So I'm coming to you as an emergency physician who's very well versed in medical care, but with another hat, I am also a member and past chair of our Board of Health of my local town. Small town, Needham, Massachusetts. It's about 30,000 people, and I often refer to it as Pleasantville. Everybody knows everybody. We have a town meeting. We have a really terrific town government and a wonderful health department. So it's with both of those hats that I come to you today. One of the things I thought I might do first is just to talk about sort of my perspective a little bit on the difference between medical care and health care. Obviously, everybody is very well versed in medical care. I work in a tertiary academic teaching hospital, which is about as technologically advanced as these things come anywhere in the world. We have, I think, 6 MRI scanners, PET scanners, you name it, we have it. But there's a lot more to keeping people healthy than simply having technology and pharmaceuticals. And I think that's sort of the focus of what we're here today, and that's about health in general. And when you start looking at the really big picture in health, at least from a medical perspective, we're looking at things like obesity, we're looking at heart disease, we're looking at a lot of different types of medical conditions that are influenced by the environment in which people live, which is really a much more holistic view, if you will, of medical care. And it's something that, at least, in my local town, I see all the time. What are we doing about preventing concussions in kids? What are we doing about noise pollution? What are we doing about people who want to put up housing projects right next to highways where there's a lot of pollution? These are the sorts of things. One very specific type of thing that relates directly to medical care is access to care. So when we talk about access, a lot of people live very close to hospitals in major metropolitan areas. That's all well and good, but do they have financial access? You have to have the right insurance, or do you have the money to see a doctor? Do you have the right geographic access? So if you're a veteran, you're covered by the VA administration. But if they don't have a hospital for 50 miles near you, you really don't have access. You don't have geographic access. How are we going to fight obesity if people don't have the knowledge of what is good eating habits, access to good food inexpensively, and know how to prepare that good food inexpensively? So these are all sorts of the differences between medical care and health care. Then when Chris asked me to think a little bit more about this and how do we address some of these issues, one of the major ways that we have found to address these, at least in the medical realm, has been through social networks, if you will. Trying to get people to modify behavior, and behavioral modification is very, very tough. What you need to do first, obviously, is have the trust of the various patients around. And that's not so easy in a medical community. Right now, we have people who don't even want to come into a hospital because they're afraid of Ebola, which is not something they should be afraid of. But again, there's a hysteria in the press that can really influence people's behavior. So we have to combat that sort of thing. So we have to build that trust. Once we build that trust, then we can use things like social networks. People trust their peers. And in trusting their peers, they can then believe in some of the modifications that we may want to suggest. I can see I'm going to go very long if I don't finish up. So let me shift it just slightly to how we would do such a thing, because I want to provide a little bit of a lead-in for Catherine here. Some of the ways that can be done, are very technologically advanced. A lot of people carry smartphones, right? Everybody has an iPhone. Most of the world does not have an iPhone. Most of the world does have cell phones, and they can use SMS messaging, perhaps. So that's one technology that we've actually tried to use to provide messaging to people back and forth on a daily basis. Works pretty well for fairly simple issues. But for very complex issues, patients who are quite ill, things like congestive heart failure, where they might need daily reminders, or a nurse coming in all of the time. That's where the expense begins to go up considerably. Now we're talking about a lot of human resources on the ground in order to try to influence behavior. And one of the things that I'm sure we'll get into a little bit later on is how we assess the value of those services. They are quite costly. Do they provide adequate quality benefits for the cost that we're incurring? Thank you.
Thank you, Steve. Well, I'm a nurse, and the context in which I want to speak with you about is, Steve mentioned trust, and nurses are very trusted by the public. And so my perspective comes from that of home care nursing, and most of my background is in transitional care, transitioning patients from the hospital into the community settings where we can work on their health and bring them back to health. So the other thing that my program of research focuses on is the use of information technology to better communicate across settings, sharing information, and making things more efficient as we are transitioning patients. So what I want to do today is give you several examples of where I think there are areas where we could greatly improve in using information technology to improve the health of our patients and the care that we provide. So the first starts in the hospital, where we're making decisions about patients as to who could benefit from further health support in the community, who needs to be referred to a home care setting for further teaching and monitoring of their medications and their symptoms. And right now that's not done in a standardized way, and so we look to IT, and particularly in my program of research, in developing decision support to help clinicians identify patients for that transition. Another area is helping patients make decisions about what kind of care they want to receive. They're often given suggestions by us as providers and not really engaged in the shared decision making. So how could we enlist their preferences in some way, maybe using technology, and then together have a conversation with them? We also spend a lot of time educating patients about self-care, about what symptoms to watch for, how to monitor themselves, what to eat, when to exercise. And the ways, I think, in which we educate are not always effective. And so I'd like us maybe to think about what ways could we use technology, perhaps video, et cetera, to engage patients better in all the education that we do. Then we transition the patient across the setting, and we try to receive them into home care. And we either get too much information or we don't get enough information. And so communicating across that chasm of what went on in the acute care setting, what now is the plan of care, what still does this patient need, is poorly done. And it's an opportunity, I think, with interoperable electronic health records we're trying to move toward, that we might be able to achieve. But we need a way to tell the patient's story. We get reams of structured notes, but we don't have a concise story about that patient. So I think that's something we could talk about. And what still needs to be done for that patient and what has been done. So we're pretty data rich, but information poor when it comes to synthesizing and presenting information. We have opportunities too to visualize information. So instead of just text and reports, but visualize over time, graphs, pictures, bar charts, circle graphs that help patients understand what we're trying to communicate to them. The reconciliation of medication across settings is another critical issue to keep people from having side effects, overdosing, making mistakes with medications. And once the patient is home, they also face challenges in communication and self-care. So what information is needed for them to take care of themselves? What are their goals of care, and how do we collect that from them? How do we communicate that to the team? And they must wonder if we ever do talk to each other, because they come out of the hospital setting where they've given their story, and then they enter the home setting and they have to give their story again. And then how do we communicate that to the PCP then, the provider in the community? So we have an opportunity, I think, to work together to build electronic health records and HIT systems that can help us do a better job. We should learn from the mistakes that have been made in acute care, where we have multiple systems that don't talk to each other, and silos of information, and information that's poorly presented. So we could use HIT as a tool in the community to help us improve health for our population. So thank you.
Thank you.
Great, thanks. Good afternoon. So I'm delighted to be here, and I just, by way of disclosure, want to mention that I'm also on the board of PA Consulting. And what I'm going to try and do in the next 4 minutes is talk a little bit about the journey we've been taking at Hiccup from a year and a bit ago, where the idea was indeed to be a health initiative coordinating council, to where we are today. And I want to call out in the audience Karen Watson, formerly with Nielsen, who's one of our advisors, sitting up in what has become the first row because nobody dares to sit in the front. So the idea of Hiccup was to do essentially almost like a clinical trial, but any self-respecting scientist would blanch at that notion, but at least a testing of the idea that if you want to produce genuine health in a community, you need to do multiple self-reinforcing things. Most community health efforts end up just being dissipated in the wind. It's, you know, you fix a neighborhood, but people go in and out of the neighborhood. You get some social network to do something, but they spend too much time with their non-compliant friends. You go into a community, you do something for 3 years, then the funding runs out and you leave, and not much else has happened. Being very modest people, we thought that we would find 5 communities that were already embarked on such a journey and then help them do it at scale. But more and more we've begun to realize that community health efforts are not really even the answer. It's not simply scaling up what's happening already. We've been talking to advisors, evaluators, technical assistance providers, all kinds of really, really wonderful people. But we're beginning to think that we really need to explore new business models and look more fundamentally at how do you foster long-term investments, not just in nursing, but in changing the food supply in schools, bringing in all kinds of programs on the medical side that will generate money. If you can control asthma, diabetes, deal with stroke more effectively, not simply care for wounds, but actually heal them, you can actually make money for the system if you have the right business model. But you can also make money for a community if you increase high school graduation rates, if you reduce the prevalence of crime, if you get your police department working with your health department. This all sounds, really nice and visionary, and totally unrealistic. We're trying to prove over 5 years that it is realistic. And I'll leave it at that. Happy to answer questions. Thank you.
I'm feeling very guilty that our aspirations are not even near as big as that. But
We're doing it in very small places.
I'm with Pfizer, and we are aspiring though to become a healthcare company, not a medication or a pill company. And on the face of that may sound, would you put yourself out of business? Fortunately for us, unfortunately, I think for the world we live in, between behavioral lifestyles and genetics, we're never going to be out of business, and we're very fine with trying to get as many people as we can to actually not need our medicines. But when we do have people that do, make sure they actually stay on those medicines. The right patient with the right medicine at the right time. And it's very scary. Kathy briefly mentioned it. Medication adherence is at best 50% for most chronic medications. Even oncology medications are not as good, better than 70%, which is very scary when you're talking about a life-saving intervention. But we also understand, and Steve mentioned this briefly, that the value equation is changing, and we're going to have to be able to bring different information to the table around that. We're going to have to either prove our products work or guarantee they work and show the value that they really bring. And it's not just to the physician anymore or the people paying for that drug, but it really is around the patient, their caregivers, and or their family, and to be able to help them as well. And part of what we're looking at is solutions beyond the pill. So how do you help a family member or caregiver understand, what are the patient's needs, whether it's around adherence or other behavioral things that they can do. We have a lot of really good information around the patient journey and the disease areas that we cover. How do we take that intellectual capital and then work with our partners to actually deliver that to people to make it helpful? And again, to the people who really are going to be delivering that, though, which is the frontline care team, whether it's the physician, the nurse, the NP, the PA, or even someone else within the office, to make sure they have the information that they need. And it's if we can help in any way with that, and patient engagement. We also do. We do patient engagement. It's called direct to consumer. You've seen those television ads. A lot of people don't like the way that we do that, but they are very effective. And we're working on trying to understand and partner with some of our provider friends to see if there's a better way to create a message that actually works for the physician organization and for the patient, as well as for us. And so maybe it's not around talking to your doctor about a certain drug, but talk to them about diagnosis, talk to them about adherence, talk to them about behavioral changes that are necessary to move forward. And then the last piece is also, starting to understand from a pricing perspective, how do we make our products more accessible to people? And we're doing a lot of different ideations with some people around outcomes-based contracting, and you only pay where it works and those kind of things. And very early on, but certainly understand that people have to have access to the medication as well as the financial access as well. So.
Good afternoon. My name is Anish Kumar. I want to speak about two things today that are my passion. The first is access to routine care, and the second is some of the healthcare ecosystem changes that I believe are exciting. And the common theme between the two, in my mind, is really a transformation of our healthcare system from a curative engine to a preventive agent. So today we are the best and also the most expensive at curative activities. And that is mostly because of the way the incentives are structured for everyone, for my employer, for the providers, for the suppliers to providers, and so forth. Therefore, maybe these two meditations, one at a small scale on access to routine care and one more from a payer perspective may help get the conversation going. So let's start with routine care, and this is really the term I use for preventive, urgent, and primary care. So excludes expensive interventions, hospitalization, and so forth, but most of the care that has been available through the centuries in a fairly accessible manner, really before our healthcare system took place. And today it has become a scheduling, insurance driven system. But the exciting thing is that in the past 3 or 4 years, new business models have started to emerge. They include retail clinics within Walmart, Walgreens, as well as freestanding urgent care clinics where you can walk in. Sometimes the prices are posted. In the vast majority of cases, they do as good a job as the traditional health benefits system, and sometimes better. They can definitely take care of routine access. The second thing that's happening, well, first, that is what is also happening with those clinics is they are extending the care team. There's a primary care physician shortage, as we are all aware of. So we really need to look at that care team with a broader lens. It includes nurse practitioners, nurses, in some cases medical assistants, but it definitely includes more people than we think of today as providing routine care. And that is coming through clearly not from primary care offices themselves, and also not from managed care organizations, but from new capitalistic entities entering this space. What is also happening is that technology is reducing the local monopolies of healthcare delivery. So it is really taking away the tyranny of distance, as I call it. So you have telemedicine with companies like Teladoc, and email, video, and other remote diagnosis type of capabilities are coming in. Today they're not really entrenched, but I absolutely see them becoming more and more prevalent, whether it is reading your X-ray or providing some sort of even diagnostic capability. My employer, Aetna, for instance, owns a company or a business called iTriage, which is an iPhone app where you can self-diagnose. And in many, many cases that we have looked at, the overall accuracy of that diagnosis for routine care is fantastic. It's better than most live physicians. So that is an example of what is happening. And that's nothing against physicians. Let me moderate my comment.
It's a challenge for you, Steve.
By mentioning that I'm an engineer by training. And imagine somebody coming to an engineer and saying, you know what, there's a new computer-aided design software package. And it works really well, and it helps you design circuits, it helps you design buildings, it helps you design airports. Most engineers will say, hallelujah, this is fantastic. My productivity just went up 10 or 15-fold. It's only in healthcare that we have stayed at an artisanal level of practice, to put it bluntly. And that's why many physicians, and this goes partly to the payment model, many physicians are threatened or could be threatened by iTriage. There is even better software available from Harvard Medical School and so forth, but I think it's a good thing. The last thing that I'll allude to, because I only have 1 minute left, is that the way payers work today is broken. Without detailing how it is broken, there are 2 ways that we can work much better. The first is what I call the Intel of healthcare, and the second is the Apple of healthcare. Intel of healthcare really means that in areas where there are strong provider practices, companies like Aetna, Cigna, United, and Humana, and others should really become suppliers to those provider practices. So they can start taking risks, coordinate care, and treat populations. Very exciting area. ACOs are really one way of getting the ultimate of that. And the Apple of healthcare, which will be my closing comment, is really for companies like ours to take over the end-to-end consumer experience and be responsible for all care, and then use providers as necessary. So those are the areas that I would welcome questions and comments through the rest of the program.
Thank you all very much. Thank you all very much for your introductions. We're going into the Q&A part of the session this afternoon now. We've already got one or two questions coming in from the webcast, so thank you. I want to start us off, however, by going back to a comment Esther made, which was around incenting the delivery of health. And in many respects, when you want to incent anything, even in healthcare, unfortunately, it's about showing you the money. So I wonder, Esther, how you think we might deliver health profitably.
So the first thing is, and I'm looking at Aetna here, is we need to have the insurance companies get into the business of reducing risk rather than simply spreading it around. And it's not their fault. It's the system they've been given. But if you go back to the beginning of the 20th century, when fire insurance companies became a big thing, they didn't simply insure you against fire risk. They went around and inspected buildings. They told you to get rid of the oily rags, to open up the fire escapes, to reduce, to make sure people put their cigarettes out in places that didn't have waste baskets with paper in them. And the health insurance companies are mostly simply passing on the risk rather than reducing it. The Accountable Care Act has started to get them doing that, but Aetna is not allowed to give people a food prescription. It's, in most places, it can't buy them a vacuum cleaner. It can treat their asthma once they have it, but it's not going around getting rid of the rats or reducing the mold. And right now, Aetna has no incentive to do that, because if it saves money, it has to pass it back, either in the form of reduced premiums or, it's negotiated something with an employer or something. And so if we were to give Aetna the chance to earn more money by actually keeping a population healthy, that would be really exciting. That's just one example of what I'm talking about. A community also, it can tax people to do this kind of stuff, but it's very hard to do that because nobody really believes any government's promise about what they're going to do in years further out. So there's this whole notion of social impact bonds that are based on pay for performance around health improvements, which is frankly something that Hiccup is trying to create a market. It's early, everybody's talking about it, but it's being done out of the corporate social responsibility budgets at Goldman Sachs and places like that. It needs to come out of their money-loving, their financially beady-eyed budgets where they see, my gosh, if we can really reduce the incidence of asthma and share in the reduced costs, we're going to make a buck.
Let me add a little bit to Esther's commentary. And first I want to say that for obvious reasons, whatever I say represents my opinions.
Oh, shucks.
Always the best way to position controversial opinions. The key point that Esther has brought up is that the current relationship between the delivery system, the doctors, and so-called insurance companies is broken. And when I was referring to these two new models, the Intel model as well as the Apple model, they are driven by that realization that the activities of so-called insurance companies, we are not true insurance companies for a number of reasons. We provide first dollar coverage, there is no limit on benefits, now we cannot do medical underwriting, and so on and so forth. We are payers with an insurance element. So our activities and the care delivery system's activities are mingling together, and that's causing discomfort, but that is necessary for the system to work well. In the so-called Intel model, you would not go to Cigna. You would not have insurance from Cigna, Aetna, Humana, or Aetna. You would get that from Beth Israel. An entity like Beth Israel or Hartford Hospital or Banner Healthcare or Innova or Stanford would say, for me to now treat populations, coordinate care, and take risk, there are 7 things that I have never done. I have never done population risk stratification. I have never issued ID cards. I have never looked at network adequacy and so forth. And companies that have been called insurance companies could be suppliers to those, to Esther's point. And that is very necessary because the model today, the confrontational model, is broken. It does not work. The second model that I brought up is more ambitious, and it only works for certain so-called insurance companies, where are there Steve Jobs-like people who will really redefine the entire experience for consumers and drive us to an iTunes plus iPhone, where the biometric and all the other technology pieces come together. The jury is out because nobody is doing this, including my employer. But the need absolutely exists. The need exists.
Matt, do you have a big pharma perspective on this one?
So, a little bit. In fact, we are very happy to see some of these changes. You know, I love the idea of going to talk with someone, an North Shore LIJ, right, that's taking all the risk and is doing all the delivery mechanism, right, and letting them understand the value because they're the ones delivering that care and closest to it. So from our perspective, we do, and so we see this whole evolution from fee for service to value based and that decision making moving downstream. The first step, I mean, Esther said, it's going to take us quite a while, but right now, all the incentives are around sick care. There's no incentives around preventive medicine or health care, but if you take a population approach, there will be. And if you've got a longitudinal approach in there, then you will be as well. So the fact that I know Aetna, Cigna, United just said they're going to move $50 billion of provider reimbursement to value. Now the question what that value prop will look like, we'll see, but I think it's a very good first step. And we like the idea. Yes, it raises the bar for us. We've got to bring value into what we're bringing into the equation as well through our medicines or the solutions around the pills, but I think it's what we all have to do.
Great, thank you. Steve, you mentioned in your piece finding the value, and I wondered about your perspective.
I'm reacting to a lot of it. We've done the doctor bashing for the day, so thank you. But the value in healthcare, if you consider value as an equation, okay, cost divided by quality plus patient experience, and that's really what this boils down to. The Affordable Care Act, make no mistake about it, is all about cost. Okay, they're trying to maintain quality, but it's about reducing the healthcare costs. Currently, getting towards 20% of the GDP, it's beginning to crowd out other things, other social needs for the nation. So we need to get the cost down. The problem is that we don't really understand what the costs are to begin with. And for that matter, we don't really understand what value is to begin with. So in order to really begin to talk about value, we have to first define our metrics. Right now, when Aetna gets a bill from me, okay, from my emergency department, if somebody comes in with a UTI, it's going to be, like $300. And I get about, $30 of that, and the hospital gets the rest. But when you actually look at the cost of taking care of that patient, it's next to nothing. The emergency department's open all the time. Patient comes in, takes me just a couple of minutes, some very simple lab tests that could be done on an outpatient basis, with just a strip, right, for about 20 cents, and then send them on their way with a prescription for antibiotics. So what's the actual cost of that visit? From an insurer's perspective, the cost of that visit is $300. Somebody is paying a bill. But I think that we need to think, and this is where value-based purchasing begins to come in, where accountable care organizations begin to come in, because within our organization where I work, we are a pioneer ACO. We have to think about what are those costs and how much does it really cost us to do this? Does it make sense for a patient at 10 at night to go to an urgent care clinic that we build at a cost? Because we might be able to do their care cheaper there. Does it make sense to send them to the emergency department because the marginal cost there is next to nothing? Should we build an emergency department? Because when you do that, you tend to build in more technology. We don't need a lot more technology to take care of the vast majority of acute unscheduled care. We really need more urgent care centers, which, as you've heard, can take care of the vast majority of a lot of the simple care in the United States. When you flip over to the quality side of things, we're very good at measuring processes. We're very poor at measuring outcomes. So right now, all of the quality metrics that the Centers for Medicare and Medicaid Services look at are really process measures. Did a patient get an aspirin if they came in with chest pain? Did they get an EKG? were antibiotics given within 4 hours of the patients presenting if you thought they had pneumonia. And we're very good at checking all the boxes. What we're not very good at is determining whether or not that actually made a difference in that patient's health overall. And again, accountable care organizations will begin to get into that because we need to start looking at, are those patients coming back? Are they coming back within 72 hours? There's real pressure not to admit them to the hospital within the next 30 days because from CMS, the largest insurer, if you will, from their standpoint, that's a failure of the medical care system. And they're not going to pay for failures. They're going to pay for results. So there's a real pressure to begin to figure this out amongst the medical community, but we really don't have a lot of tools to do that yet. And that's what I'm hoping we're going to start to develop.
Great. Before I come to you, Kathy, I wanted to supplement the value question with one from our webcast from Adam Weisblatt. And he asks, what role should public education play in creating more health in the community? And I know you focus quite strongly on the education aspect up front.
Public education.
Yes.
Yeah. Well, I've been thinking about this in terms of working with patients in the hospital and trying to help them understand what their options are. And people don't understand what a home care nurse does and the functions, the value of that service, and I'm sure the value of many other services, including taking their medications as they're supposed to. And so I think the television set is a terrific way for public service announcements, commercials, to get those messages across. I think it's a powerful tool and one that I don't think we use enough. There's other venues, the school systems, the health classes. How much of that is in health, focusing on health promotion? And I think it has to start from a very early age and be used with the entire family.
Great, thank you. Would anyone else like Matt?
Yeah, I think it's interesting. It's not just the schools though. Public health funding has just diminished greatly. And you could argue the value, and I think some states did it better than others, but we're putting very little resource into that area, and there's a lot of really good success stories around what public health has been able to do. Public health departments within the states have been able to do, but they've been crowded out by all these other things. And I'm my opinion as well, not Pfizer, is that there should be more funding to that because they're actually doing some of these preventative measures with the highest risk patients, and we've just continued to drive their funding down and down.
Right.
But it's also worthwhile keeping the low risk patients low risk. Most of the high risk patients used to be low risk, and then they started eating badly, didn't get enough exercise, lived in places that eroded their resilience. They started smoking. I mean, there are some people who genetically are likely to get a disease, but most people started out low risk, and it's trying to stop that. That's where you get the biggest return, but it's a much longer cycle.
I agree with Esther. I was just at a conference called The Future of Home Care, sponsored by the Institute of Medicine, and several people presented about their creative programs that are working to keep people healthy, but they were targeting the most expensive 5% of the population. So those that were using a lot of healthcare resources. And I made the comment that I'm concerned about the other 95% of us that need help in staying healthy.
Right.
So I've met the highest economic or demographic risk, not clinical risk, but because I agree with you guys. If you can stop it, I mean, that's population health's idea, right? The pyramid, if you can stop people from moving up that continuum, there's so much more savings than trying to treat it afterwards.
But that wasn't the group they were speaking about when they were
Good
talking
point.
about their targeted audience for their programs.
It's the highest cost, which people are unfortunately already in that bucket.
Yes. I mean, it used to be we didn't know this, and so there's some excuse for it, but now we do. And unfortunately, we're not paying attention to it because we're in such a short-term world, including both election cycles and financial cycles.
Thank you. I'd like to open it to the floor now if you have some questions for the panel. And if you could just give your name before asking the question, that would be fantastic.
And your patient ID number, please.
Your blood pressure and your blood sugar.
And are you covered?
Carlos Ariza. My question is about the integration or the bleeding of the boundaries in healthcare. You know, and we have really most of the components of the healthcare system represented here. And how do you see that evolution? And maybe it's a question for a whole panel of how, you know, Aetna, for example, going out and becoming a hospital owner, and Pfizer opening clinics, and, you know, Beth Israel getting into insurance. So how do you see that evolution happening? How fast, or do you think the next election cycle is going to derail that and bring us back to the old world? I don't know.
I can start with my thoughts. Personally, I think it's a great thing. It's a great thing because we've worked in these hyper-specialized roles for so long that we have lost a view of the patient, of the holistic societal cost and value. We know it's 18% of the GDP, but why is it 18%? To Steve's earlier point, has been lost. And then why are our macro health measures so poor? So getting into one another's space brings in new looks, new competition. Another aspect that we haven't necessarily explored on this panel yet is that there are new entrants into the industry for the first time. But by the first time, I mean at scale. There have always been new entrants, but it's a highly regulated industry, requires specialized knowledge, at least for service delivery. Therefore, you have not had disruptors of Silicon Valley type coming in. If you look at the venture funding over the past 2 or so years for health, IT, and health startups, it has skyrocketed. And those new companies don't fit into traditional buckets of insurance companies, providers, pharma companies, home health. They are category busters. And that is fantastic because all of them are creating value for the ultimate customer, who is the consumer. So I think it's a great thing. It will happen sooner than most incumbents believe. So definitely in the next 5 years or so, we'll see a completely different system.
Pharma we will not be buying a provider organization, I can tell you that. But I agree 100% with what Anish just said. I think you have to have an integrated system to really make it work. And you know, we briefly talked about what's going on in the marketplace with you know, merger and acquisition. And I read something recently. I'm not sure if I believe it. A consulting company thinks there'll be 40 health systems in the U.S. by 2020. I think that number's too low, but it's not going to be the 12,000 it is today. And because if you want to do population health and have to have that integrated, you've got to be either own or be aligned to all the places those patients go. And I think that will be better. As Kathy said, people will be talking to each other because they're all going to work for the same organization. And once we get interoperability in EHR.
Right,
Yeah.
that's a big
Yeah.
win. Yeah. I wanted to mention that the Visiting Nurse Service of New York is branched into population health. So we have a large program we've just started up with Empire Blue Cross Blue Shield that we're taking patients from their ranks and providing population health services for them. So home care is also crossing boundaries and starting new programs other than the traditional, you know, post-acute sick care in the home in the form of population health.
And I see it happening in a somewhat different way, more along what Anish was talking about from Silicon Valley. It's not that all these guys are going to combine, but rather that newcomers are coming into the crevices and eroding some of their power. At the same time, they're creating not just, quote, big data, but data liquidity, which means your data can move around and do useful stuff instead of being stuck in one place or another. You don't need these companies to merge if the individual can get her health records from 4 places and combine them in she doesn't need to do it. Some software will say, my gosh, you're taking 3 drugs. They've got different names, but they're actually conflicting, and that's why people don't take their drugs for a whole bunch of reasons. One is they don't like the side effects. There are others, including cost and including not wanting to feel like a sick person. But in many cases, the providers don't really have a picture of the whole patient. And then there's all the other stuff, which is that health is not just medical. Health is somebody saying, you know, I'm not going to go to the doctor. I'm going to go to a movie. That'll make me feel better. Or, you know, maybe I'll go have a drink, or maybe I'll go have 5 drinks.
Maybe you shouldn't have 5 drinks. But I think one of the themes that I'm picking up here that I wanted to bring up is fragmentation. As much as the ACA has moved us to accountable care, so larger organizations caring for populations, you're seeing that these disruptors are actually fragmenting that care to some degree. The goal of the ACA was to create organizations like a Kaiser, like an Intermountain Health, some of these very large organizations, integrated healthcare systems that are both insurers as well as providers, linked together so that their incentives are all aligned. The ACO program begins to do that. You need to have enough scale to do it. There are a couple of major metropolitan areas doing it. Boston is one of them. We have, I think, 5 ACOs in Massachusetts right now, some of which have been successful, some of which have not been successful. And the idea is that this whole thing is going to be rolled out to the nation eventually. But each one of these groups needs to find out how they're going to manage their population. The problem is, how do you define that population? And right now, the population is defined by where a particular patient gets most of their health care. Now, my primary care provider, to give a very clear example, works for my competition. He used to be with our group. He left years ago. I still see him. He's a great doctor. I like my doctor. And most patients love their doctor. Because as much as we've been talking about, to some degree, the commercialization of medicine here, medicine is not just a science, it is an art. And knowing a patient and knowing what they're thinking is really important when it comes to making the more difficult diagnoses. And that's sort of where the rubber hits the road a lot of the time. But when you have a patient, that I see coming to the emergency department who's been to, one emergency department, didn't get an answer, went to a different urgent care center, didn't get an answer, saw their primary care doctor, didn't get an answer, so finally comes to me. And none of those systems talk to each other. One might be on Epic, one might be on Cerner, one might be homegrown. None of them talk to each other. And to some degree for very good reasons, because of HIPAA compliance. So there are a number of technical and ethical issues that need to be sorted out in order to do that. That fragmentation, however, makes the care of that individual patient much, much more difficult. So if you're going to truly build a patient-centered universe, we can't be assigning patients based on, it'd be great to assign patients actually where they get most of their care, but then you have to ask patients to kind of stay within the box, if you will, to say, this is where you get your health care. You can select wherever it is, whatever resources you want, but the best care for you is going to be within that box where it's all coordinated instead of going outside of the box. And I don't know if the American public is ready for that just yet.
One point I'd add to Steve's comments is, yes, another way of looking at this is unfettered provider choice that we have taken as a God-given entitlement is going away. There is no economic model that can sustain that. Medicare, the biggest insurer, as Steve called it, does guarantee that, but as a society, we are going to run into the economic unsustainability of that model. So the choice of providers at any moment is going to go down. At the same time, the number of people who serve that provider community is going to go up, meaning that you could have a ZocDoc that helps Beth Israel with appointments, or a Castlight Health that helps the consumer and maybe the payer with some types of transparency or comparative therapy effectiveness tools. And the fact that people like ZocDoc and Castlight Health are entering the system, to Esther's earlier point, is great news. Because the honest answer is that people in the industry, whether on the payer or the provider side, have not provided these services after decades. So we have failed the consumer completely on providing convenient, technology-enhanced, affordable access to healthcare, and these people are doing that. So that is great news. So you really have to combine the two dynamics to see the emergent future where people will choose their provider system, and it will be a subscription model of some sort. And like with most subscription models, if you have a subscription at YMCA, you cannot go to Gold's Gym and get fitness. So yes, so you are going to be tied at least for a period of time to that, but there will be more tools. There will be many more tools available to the delivery system, and that's great news.
Thank you all. Let me ask for another question from the floor. Just on my right here. Oh, well, go ahead, please.
Thank you, Michael Lewis. We've talked a little bit about new and innovative care delivery models and also reimbursement models on the other side of the coin. Wonder if we could get a perspective from both a provider perspective and a payer perspective on the pros and cons of ACOs, for example, and as a follow-up, some additional new care delivery models such as care bundles, and perhaps additional some alternatives to those as well.
Would you like to lead on that one, Steve?
Sure. I think you're talking about episodes of care when you talk about care bundles. That's so an episode of care basically is a payment model in which a patient comes in with a particular problem, and from the beginning of treatment, wherever and however that starts, to them returning to full functioning is considered an episode of care. So, for instance, somebody who's having a heart attack, from the moment they develop chest pain and call 911 to their arrival in the emergency department, to being taken to the catheterization laboratory by a cardiologist, being discharged from the hospital and under the care of an outpatient cardiologist and a nursing team, to be getting back into the workforce, fully functioning after physical therapy. That is one episode. And the proposal has been made that CMS wants to pay for healthcare based on these episodes. So, I equate this with the old Greek legend of who threw the apple. I'm trying to remember who it was who threw the apple, and to Aphrodite, Athena, and Hera, and said, "To the fairest." And they all started fighting over the apple, and that's kind of what's going to happen, I think, with healthcare. One of the ways that we have to actually apportion the apple, if you will, is something called the relative value scale. It's something that's been in effect since 1996, where we tried to determine the relative amount of both technical as well as non-technical knowledge-based work that physicians and other providers give to a patient. But you have to say when you're doing that sort of thing, you're all in a room. It's like, well, what's more important? Well, I think that what I did, diagnosing the heart attack and getting the cath lab is very important. The cardiologist actually did the procedure. You can see where this goes. So I don't know if that's in and of itself necessarily an answer. It's an interesting way of thinking about it because it does get back to restoring patient health. It's not about all of the various procedures that you provide. In fact, there's an incentive, obviously, under such a system to do the minimum possible. So if you're going to do the minimum possible, because this is really a cost-saving technique, because that's the way people are going to make the most money, how do you assure the quality? And that's sort of the stick, if you will. You have the carrot in the payment, and you've got the stick in the quality, except we don't judge quality very well. And right now there are a lot of efforts being made to rethink quality. As of 2016, a new system for quality reporting is going to be in place, and physicians who do not comply with that will be subject to a 6% pay cut, which is pretty significant from CMS. And if it is from CMS, usually all the other insurers nationally are going to follow that. Getting back to sort of the ACOs, though, as a whole, it is population health, and it is a very different way of thinking about it. But it goes hand in hand with episodes of care and bundled payments. I mean, you're able to hopefully control to some degree soup to nuts patients, except for patients who go out of the system, as we just talked about. But again, the incentive there is to discover how you can develop and deliver the best health care for the least cost, because that is how you're going to survive. So the incentive is correct. We don't yet have the tools necessarily to do that. We've got a lot of data. We don't have a lot of knowledge from that data just yet. We can collect all this minutia, but putting it all together from all of these disparate systems that can't talk to each other, really isn't there quite yet. So there are going to be a lot of growing pains in this system from the provider standpoint.
Just before we move to Anish, Eris through the apple.
Eros, thank you.
The wonders of Google. Anish.
Fantastic. So I think of the ACO model as this aspirational gold standard that will apply to large parts of the country, but large parts will not be ready for that, simply based on the local provider dynamic, the density, the fragmentation, the competition. Therefore, assuming that 100% of the population will move to an ACO model where you get treated by one risk-bearing entity, a Geisinger or an Intermountain Health, is perhaps a little unrealistic. So that's one thought. The second is episodes of care or bundled payments do have certain salutary positive attributes. One of them is that they finally bring healthcare service descriptions to a level that most consumers understand. So today they really exist at the CPT, ICD-9, modifier codes, lingo that CMS and insurance companies and providers use. That's really Greek, to build upon the previous example, to most real people. However, whether it is this heart attack example that Steve had, or whether it is LASIK surgery or knee replacement, these are things that consumers have an intuitive understanding for. And getting to that type of care for certain subsections of healthcare, not all of it, but certain subsections, is a great thing. It also fosters competition. So one of the cultural dynamics I want to bring up is that as a citizen, as a consumer, giving all of your healthcare to Hartford Hospital or to even to Harvard or Stanford, it goes a little bit against our grain. We are not really wired that way. We are not Russians, although there is nothing wrong with Russians. We are, as Americans, we don't really would want to trust something that is so close to our soul to one entity, no matter how good it is. And a competition for these episodes of care, let's say LASIK surgeries is a somewhat trivial example, this heart attack example, total patellar or knee replacement would be another one, would keep the delivery system competent, on the edge, and really efficient. So somehow mixing these two, or a coexistence of these two, is fantastic. I think it would be great.
But there are some important downsides to this whole thing, because a lot of the data is not risk adjusted. So if you go on to CMS's website right now, there's a consumer portal, and you can take a look at the quality metrics and the results from various types of surgery. So for an episode of care like a hip fracture, you can find out how much it costs. You can find out how many post-operative infections there were, what their success rate was, basically. Remember, the quality metrics, first off, are all process measures. Secondly, they don't take into account that there are some places and some doctors that are willing to do high-risk procedures, and there are others that don't. A real case in point came here in New York, where a number of hospitals stopped doing high-risk cardiac catheterizations because it was hurting their numbers. It made them look like they were doing a bad job.
Interesting. Esther.
One more point is not to underestimate the resistance to change. I'm just curious, how many of you exercised for more than 20 minutes today? Okay, not bad. How many of you know you should have? The same thing with large organizations. We know how to stop MRSA infections. We know how to dramatically reduce all kinds of problems, including asthma, including various kinds of readmissions, including how to heal a wound rather than simply care for it year after year after year. But so many of these things don't happen. And incentives help, but I'd rather invest in Iora Health than invest in the hope that some large organization is going to change rapidly. I'm really glad we're starting. I really believe in ACOs, but I'm skeptical.
Thank you. Let's go for our next question.
Hi. Actually, if you look, I agree with you about.
Name.
Oh, I'm sorry.
And-
My name
and-
is Liz Solomon.
From,
I'm actually, I'm a healthcare marketer, in search of my next adventure. My question, and I agree with you that change is, very difficult. But we have examples in our society of how over time, and granted it's been a long time, we have managed to change behaviors that are health positive, such as seatbelts, such as smoking. So they are there, and there can be others. My question is, you raised the issue of marketing and talking to consumers, which is what I believe in 100%. And you talked about public service announcements, which, to use another phrase, that's the corporate social responsibility area of media. But what happens with marketing dollars and marketing messages is that they are so tightly regulated in our industry. Certainly for the pharmas, but also for payer provider, when you get involved with the Department of Health. Clearly, no one wants to give a deceptive message, nor does anyone want, or any organization with integrity, to talk over the head, if you will, of some consumers. But how do you feel about the issue that we could be more effective and more reactive as healthcare marketers if there was a little bit less red tape in the system?
Just a little bit less?
Is that a loaded
Yeah.
question?
I'd like to speak to that. So I've been thinking about creative ways of doing this. So I think we have opportunities when we have consumers as captive audience. So they're sitting in our waiting rooms. They're sitting in our emergency rooms. They're waiting at the pharmacy. They're sitting in the hospital bed. They're captive audiences. They're sitting there with nothing to do. I think that's an opportunity where we can bring something to the bedside through the TV in the room, through an iPad at the bedside, that can give them entertaining, engaging education about improving their health. And I think the home care nurse can, patients are there with their TV. We find really, no matter how poor they are, they have a TV. And they're sitting in front of that TV a lot of the time. And so messaging through some devices that could work through our TV sets, like some of the telehealth equipment is beginning to, that can, certain times of the day, deliver these messages.
Those messages, depending how, and that's great, and I think that's, something that we need to be doing more of taking advantage. But even those messages, depending on who's saying what, and who the regulator authority is, in New York, for instance, with DOH, that would still have to go through the 120-day approval process.
Yeah, well, yeah, okay, but, so there's a company that I saw that used video, that if you were a 75-year-old African-American with a 6th grade education, in the video, they used a 75-year-old African-American male who spoke your language. So it was, someone they could identify with that helped them to understand the message. So that kind of matching, I thought was really, really creative, and I think could be very effective. It still needs to be tested, but it was I thought, a really novel, great idea. I see some of these products are being used in hospitals. I'm from Pennsylvania, so I don't know that there's as much regulation there, because they are being installed in hospitals and being used at the bedsides. So I'm not sure about that.
I'm on the board of 23andMe, so I have some real experience with this issue. I think it's going to change over time, and it's not simply a question of reducing, I mean, regulations are good because they keep people from lying and they make sure that the messages are accurate. But the state of people's education about health is woeful, and it's not just the patients, it's also the doctors, many of whom never had a chance to study either genetics on the one hand or nutrition on the other, and those are both things that are really important. People don't understand how this affects them. People don't understand what risk means. Part of it is public education in the schools. Part of it is more access to personalized information in a way that is meaningful and intelligible to people. It's changing very, very slowly. I think the government is a little too risk averse in many cases. At the same time, there's a whole lot of snake oil salespeople out there, and the challenge is how you do that without the red tape.
I also think on that point, though, Esther made a point about how change is so hard. And I think it's important to, I was recently, so I'm, stated this holiday and I'm really smart, right? I recently read this book, and so I have to be careful, but about optimism bias. And if anyone's ever done any studying in that area, I've gotten very intrigued, so I've been studying since. We don't ever think it's going to happen to us, right? I mean, so an example, they asked people, what do you think your odds are of getting your identity stolen through a credit card? And the average was 30%. And then they showed them statistically, the average is 70%. And they asked them the next time, it went up to 33%. So, I mean,
But your odds of getting Ebola are around 50%, right?
yeah, but what people. But I think, but that's it. So the activation, right? It's not only the message, but the activation, right? And this, I mean, that's a great example. So Ebola has created this sense of urgency that is actually overinflated, right? So it's not just the messaging, but I think it's the surround sound we have to put around that to actually activate people to realize if I smoke, it will probably. I have a more than a 50% chance of getting lung cancer, right? Not the 5%. I think that 50% is everybody else. And unfortunately, there's a lot of that mentality out there today. It's education and then other ways to activate people, which means you have to get closer to them on the ground to help them understand it better.
I'd like to pick up another question now, if we could. Thank you for your responses. Amy.
Yeah, thank you. My name is Amy Burke. I'm with PA Consulting, a clinician by background. I have a question for both Anish and Matt in regards to ACOs, and specifically as we see more payers insert themselves in the ACO strategy overall. How is it that you see yourself in terms of sharing disease management responsibilities, improving outcomes, and also in the pharma space? As outcomes become more pervasive and we have to prove them, how is pharma going to engage in that? And I think you touched upon in terms of there's a solution beyond the pill, but just as we move more towards outcomes-based medicine, how is that going to evolve?
Yeah.
I can start with one perspective, which is, first I want to clarify that there are many press releases about ACOs and there are ACOs. And the latter is a small subset of the first. So most payers will say we have 100, 150 ACOs, and most of them are narrow network type of steerage deals. They're not true ACOs. Aetna does have a couple of true ACOs, but the number is in single digits. And in that context, I believe that over time, the delivery system is clearly best suited to provide disease management. Even large national players, Aetna, United, and so forth, we have thousands of nurses and so forth, but I do believe that it is going to be hard to bring in that customer intimacy that Steve alluded to earlier, knowing the local population and the local dynamics for nutrition, exercise, and so forth. So the disease management programs that have existed until now focused on the very sick people really need to expand to people who are not sick, as Esther was referring to earlier, so that they stay not sick. And that can only be done by the delivery system.
And as far as Pharma, actually, I'd probably mention, anyone that I think is a partner or supplier to the provider system. I mean, we're going to have to be able to bring evidence that shows the relative value of what we're bringing compared to current treatment, right? Which isn't, no one has, I don't think, placebo in their protocols, right? I mean, you have to compare it to current treatment, which means you're going to have to truly differentiate it or think about how you're pricing those products. I also think that we're at a stage where we do have intellectual knowledge. I mean, if you think about the fact that by the time you, as a pharma company, when you bring a product to market, you've got 10 plus years of experience now with that we should be sharing more of that. You know, that value will be limited because in the next, depending on who you believe, 3 to 10 years, harvesting that data out of the EMR will be better. They'll eventually have much more data, large provider system than we do. But at this point, if we have all this information that can help someone understand how to use whatever, whether it's a medication or whatever we're, quote, selling them, how and where to use it that will provide more value in the system, we need to be sitting there with them and sharing that with them. Yeah.
Great, thank you. I wanted to go to our audience on the webcast for one more question, just so we give them a chance. And this is from Gay Bach, and it's a follow-up to actually a discussion we had earlier, and she's exploring what is the role of public health initiatives, more broader than just the education aspect we were talking about, in the dialogue. And she says, per Esther's suggestion, why should removing pollutants be the responsibility of the payer? Can providers and payers force government public health to be more relevant? Big question. Would anyone like to take that one?
In theory, yes, they can, but somebody needs to allow them to. I mean, Aetna can go and say, hey guys, please get rid of the pollution so that our patients will be healthier, and it may or may not work. I don't know, maybe you have to start paying off politicians, but that really isn't what I want to see. I mean, it's something, this is why we're going to small communities, because we believe you can do as collective action what would be perceived as government interference or bribing politicians in larger places. And it's clear that this is not going to be solved at the national level in any serious way. It's too big and too complicated. What we're trying to do is solve a bunch of these things in places of 100,000 people or fewer in order to provide examples that will then inspire people to do some of the same things in larger places where it's much harder and where some evidence of what it's like when it works will help them make their case.
Thank you.
One point I'd add is I agree that the private sector, the healthcare industry, has the primary responsibility for the factors that impact the population's health. One fact to remember, however, is that 60% of healthcare in the United States is paid for by the government. Therefore, if you're afraid of us ever becoming a government-paid healthcare system, we're already there. Whether you consider it good or bad. And CMS, honestly, has the biggest hammer for any systemic change that they want to create. Now, how they use it, whether they're wise or not, is for another panel perhaps. But there is great power with that organization. So they also have a role.
Yeah. Unfortunately, in Niagara Falls, where we're working, the government allows people to sell cigarettes tax-free, and Niagara Falls has a smoking rate of 37% versus the national average of around 20. It's the same on military bases, and it's that's why I'm not expecting much help from the federal government.
Right. But some of this is government-based. I think the question said, why isn't insurers getting in this space? Some of this is really a government responsibility and not necessarily an insurer responsibility. And I think it's important to distinguish where that line is. And if we're going to blur that line, then we need to realize that what we're really asking for is a government-based healthcare system, a single-payer system. And there are pros and cons to that, which again would be a whole nother panel. But that is one of the pros of them. Also, speaking to scale, because Esther mentioned doing this in smaller communities, it really is a community-based effort. That's where the social networks work. But communities can be of various sizes. And I think that part of the issue here is how do you define that size? Even for an ACO, if they're trying to define a population, You want to have, for population health, you want to have the largest population if you're going to try to spread risk. But they might not actually be a community that talks to each other that actually is effective in solving a problem within that community.
Thank you, Steve. There's a lady in the front here.
Hi, I'm Caitlin McQuilling. I'm a health economist, so that's kind of where my question is coming from. But as we talk about more and more ambitious health models and population health, and as we talk about finding value in healthcare and paying for value, I think what we often don't want to talk about is what do you do about things that aren't valuable? How do you say no in the health system? How do you tell a physician they need to stick to a pathway? Or how do you tell a pharma company that their drug's not going to be on a formulary? These are difficult questions that we in the US won't touch. Saying quality is like saying a 4-letter word, but in Europe they have systems of putting thresholds on value, and in America we don't want to do that. But can we avoid doing that?
Good question.
Well, we do that to some degree. We're, death panel discussions aside, which is one place which we did not go. Physicians do adhere to guidelines in many cases. Physicians, to some degree, are trained as scientists. So what they want to see is that there is evidence that the guidelines work. If you tell a physician, look, this is an evidence-based guideline and can actually demonstrate that it's that, you're actually going to get reasonably good adherence. Now, just because somebody publishes one does not mean that the universe is suddenly going to actually go forward and do it. As you probably know, it takes a long time. No physician ever wants to be the first to do something, and nobody ever wants to be the last. So it takes a long time for those things to get through the system. But evidence-based guidelines to some degree do work. The Agency for Healthcare Quality puts out a number of these guidelines. You can actually sign up for a listserv, and they will send you every week the latest changes and latest new guidelines that are out there that are all evidence-based. So that kind of makes sense.
What I would add to that is clearly necessary, and we need more of that, is the incentive system has to work correctly. We're all resilient actors. Therefore, once we are paid for keeping populations healthy, some of us will go to guidelines. Some of us, without guidelines, will really stop doing things that we don't need to do, and we are doing them today because the payment model makes us do them. And most doctors are self-aware. In fact, all of them are highly self-aware people, and they know that their activities are being driven by incentives as they should be. So the incentive system, once it changes, it will also make things better.
And from the pharma perspective, we would welcome it as well. I mean, I've done a good amount of work in Europe with our company and the NHS, and I do appreciate it. You get into discussion of rationing, right? But there's some tough things we're going to have to tackle as a society, like end of life care. But from a pharma perspective, it's in the U.S. about 9 cents of every dollar goes to drugs, and in the U.K. it's 16 cents. The pie is smaller, but they see. Once you've got over the hurdle of differentiation, they see drugs as investment, not as a cost. So it wouldn't be a bad thing for us as long as we're bringing the right kind of products to market. So,
I agree with what all the others have said about evidence-based protocols, and I think that if we can use the electronic health record to its maximum to create what has been called a learning health system, that we're using the data that we're collecting as we care for patients to get smarter and smarter about what's the right thing to do and what works for certain people and doesn't work for others. Over time, these protocols will get even better and more evidence-based. So that's my hope for EHR data use.
Great, thank you. We probably have time for one or two more questions. Do we have any more in the room? At the back.
Hi, Justin Hughes with PA Consulting. One of the things that the automotive industry has done in order to tackle insurance costs or to look at insurance costs has been offering people the opportunity to put a black box in their car and monitor the data from that. And I think you can possibly see where I'm going with this. But as somebody who has occasionally underestimated to my doctor how much I've had to drink the last week or what I've eaten, I would have no problem sharing more data with my physician in exchange for a lower cost structure or a different cost structure. What do you see in terms of the health industry and how willing the patient is actually to move into a more should we say, a sort of more sharing basis of what their data is, as opposed to just relying on what you're told when you first see that patient?
That's interesting. And healthcare is the only insurance scheme, scheme is not bad if you talk in the EU, by the way. So that in the U.S. that actually isn't somehow paid for differently based on your contribution to that risk, right? Auto insurance, homeowners insurance, if you're too far away from a fire hydrant, all those things we pay if we're, putting ourselves at more risk. We don't with healthcare, and I know that's very unpopular, but I think we're going to have to, personal opinion, eventually look at that.
It's certainly happening a lot with a lot of employers. I mean, some of the stuff they measure I don't think is that interesting, but in other cases it is. And it's controversial because, somebody did a study and they discovered that 79% of people thought it was great if you got a reduction in your car insurance if you had no accidents, but they thought it was unfair if you were penalized for having an accident. And,
Yeah.
But I think you're talking about a little bit about a difference of scale here. When you talk about auto insurance, we're talking about the difference between maybe $500, $2,000. Okay. When we're talking about differences in healthcare insurance, we're talking about many thousands of dollars per year. And that's for individuals, let alone families. And when we start talking about, the high deductible costs, high deductible insurance plans, that cost may come down somewhat. That's certainly a place that is of great interest because of that. But it gets to be a lot harder to try to differentiate away from community rating, which is really where the ACA went. I mean, the idea was health insurance is very expensive. Why is it expensive? Because medical care, let me correct myself, medical care is so expensive. That's why insurance is so expensive. It is so expensive that many people cannot afford it. And if we're not going to bankrupt people, we need to be able to effectively try to get everybody to get insurance. The only way to do that is community rating. So what you're suggesting by giving a discount would be to say, let's go away from community rating. Let's start rating people by gender, by smoking. Let's check their blood pressure, because we know patients with hypertension tend to develop heart disease and stroke and the like. Pretty soon, you're going to have people carving out and insuring the low-risk population, and nobody wants to touch the high-risk population. Far too expensive. And that's something, again, that really is a societal discussion, and thus far, based on the discussions that we had when the ACA was passed, that's something that we want to provide insurance to everybody. We see that to some degree as a right of citizenship.
2 points. One, the philosophical point you brought up, and second, a practical approach from employer's side. So philosophically, the problem that we're all grappling with is that when you look at serious illnesses, some of them are a result of behavior, lifestyle issues as we call them. Some of them are not. They're a lottery that you lost. And it is hard to separate the two. So anytime you start penalizing people for having serious illnesses and then they have a congenital heart valve defect, you're really condemning people for something that their behavior did not contribute to. And that is the icky question that there is no good answer to. You'll end up with one or the other. Now, coming to a practical approach, what many employers are doing is moving to these so-called defined contribution funding strategies. And what that means is that instead of defining the benefit that they will provide to their employees, they are defining the contribution, $8,000 a year, for instance. And then employees who are sicker and may want a richer plan will pay more out of pocket. Employees who are healthier can buy lighter weight plans and use that money for something else. So de facto, it does take away community rating for the 2/3 of the American population that gets its health benefit insurance help from employers.
And I understand, though, you can't, to the example you just said, you can't differentiate that, but I can differentiate a smoker versus a non-smoker.
Sure.
Right? And we certainly don't want to break anyone, but community rating doesn't create any kind of differentiation. You could still provide the incentives that they do today, to let people, I mean, if you're, living your life badly but are very poor, we're going to pay for it anyway. But it's the people who are living their life very badly that can afford it, I think we should be paying more.
I mean, employers can also do other things. They can offer gym classes. They can, there are lots of ways to incentivize people beyond attaching it to your insurance payments. And that's what we need to do as a society, not simply as an employer. You know, again, it gets back to this really boring stuff like bike paths and healthy food and, you know, making smoking even less popular. God bless CVS, and I hope the other guys follow them.
So on that good thought, I think as we're getting towards 6:30, we need to bring it to a close. I do want to thank our panelists. Thank you so much.
Thank you.
Great job.
Thank you.